What up, tribe? Welcome back. Sorry, a little late. Promised you for a YouTube live several hours ago. It happens. Come on, you should know by now. I'm not the most reliable when it comes to scheduling. I'm gonna do YouTube live today on enteral feedings for a patient who's intubated and on a continuous paralytic drip. Gonna try experimenting with YouTube live in the middle of the day. For those that catch us on the record, thanks for joining me. I'm still trying to figure out whether we're gonna do YouTube live here or we're gonna do Facebook live, trying to integrate this into my reborn podcast. We'll see how it goes. I'm not going to waste a whole lot of time. We're going to jump right into this. This is going to be short, sweet, to the point. Hopefully we get a couple people that'll join us on the live broadcast. I'm going to open up the broadcast on my iPad so that I can see the chat. So if you're in the live feed, if you're hanging out during the live broadcast, I'd love to hear from you. Wave hello, give me a thumbs up. What up? A422%. We have Patty in the audience. Thanks for joining. Still in the experimental stage on figuring out what's the best way to work on the podcast and everything else. So we're going to go with it and see how it goes. I've been neglecting the YouTube Nation. I apologize. So this was a question from someone on, I believe, Instagram, was asking me a question about tube feeds. This nurse, I think, is a newer nurse and was asking a question in regards to enteral feeding for patients who are on a continuous paralytic. So let's go over a couple of the details. I'm not talking about paralyzing someone permanently. You put someone on a paralytic when they're really, really, really sick, or you're having difficulty with them communicating on the ventilator appropriately. And we're probably going to leave it at that. So paralytics are used for a variety of reasons. In the current state of affairs, the paralytic could be used in acute respiratory distress syndrome, ARDS, ARDS. It can be used in someone who has refractory bronchospasming. There's a variety of reasons. We're going to leave it at that. So a continuous paralytic is something that must be monitored by the ICU nurse at the bedside, and it needs to be cognizantly, continuously titrated for appropriate effect. Neuromuscular blockades come in a variety of flavors, and we're not going to dive deeply into the different types of neuromuscular blockades. There's a couple that you can use as a continuous drip. There are a couple that you can use as an IV push. In this particular case, we're going to talk about a particular medication that is used as a continuous drip. And commonly, or it's the most commonly used medication, is cistatricurium, which is sometimes called Nimbex, N-I-B-E-X. There are other facilities around the globe that use different types of paralytic infusions. I'm going to refer to most paralytic infusions being Nimbex because of cost and effect. The problem that most people run into is in your brain, you're thinking to yourself, okay, well, I'm paralyzing my patient. And remember, chemically paralyzing your patient. I'm chemically paralyzing my patient. Therefore, I shouldn't be putting stuff into their stomach, right? That's bad. That's all sorts of badness. If I'm going to chemically paralyze them, I'm purposely stopping them from moving, then why in the world would I put nutrition down into their gut? Chris, glad you could join us. Thanks for joining us for the live feed. For those of you who are joining on the live feed, what's up? And say hello, wave, make sure I know you're there. Talking about enteral nutrition for the chemically paralyzed patient. So you have a patient who is on a continuous chemical paralytic, and the nursing staff, this particular nurse wants to know, first of all, why are you feeding them? And second of all, why would we use only trickle tube feeds? And that's the question that was asked, which prompted this YouTube video. So let's start off by talking about trickle tube feeds. Trickle tube feeds are used for a variety of reasons. Mostly we're using them to prevent other problems. Trickle tube feeds by no means is adequate nutrition. They're barely what we call trophic feeding, which is giving enough enteral nutrition to the point where it's sustaining enough protein, carbohydrates, enough nutrition to augment the processes in your body. Someone asked a question about tube feed residuals. Get to that in a second. So trickle tube feeds are literally just going at a trickle rate. So 10, 20 cc's an hour is standard. There's no right or wrong. Every facility's different. 10 or 20 cc's, and all you're doing is stimulating gut flora. You're doing nothing else other than that. And the whole point of why you're stimulating gut flora is you're trying to prevent translocation of gut bacteria. And in simple terms, that means that the bacteria that's in your gut, remember, you have normal bacteria in your gut. You have normal flora in your gut. It's supposed to be there. It's common. It should be there. It helps digest, helps keep the acidity level in your gut to make sure that you're processing all of the food that you're putting down there. You have normal flora in your gut that are only supposed to be in your gut and nowhere else. And when you are put in a stressful situation in the ICU and you're intubated and you're on medications that change the acidic level of your stomach, the pH level of your stomach, what can happen is that gut bacteria can translocate into other parts of your body. It can actually seep into the brain fart. I don't know the name of the actual structure. Sorry, just gonna have to go with that one. But it can actually seep into other parts of your body. You can actually get bacteremic. You can actually get pneumonia from translocation of gut bacteria. The stuff in your gut can reflux up into your mouth, and then you can suck that into your lungs. Even while you're intubated, it can still happen. It can travel down the ET tube. It can travel around the balloon of the ET tube. It can travel around the gastric tube that you have, whether nasal or oral. And you can have bacteria go from your gut to other parts of your body, which can cause all kinds of badness, the least of which is pneumonia, the worst of which can be bacteremia. So what you do in order to prevent that from happening is you stimulate the gut. You stimulate peristalsis. You make sure that what's inside of your belly is still churning and burning along, regardless of being on the ventilator, regardless of all the other illness processes that are going on while you're in the ICU. And I'm only talking about ICU level care. So now that you've stimulated the gut by using trickle feeds, you're going to try and prevent all these processes. So back to the question at hand is, why in the world would you want to stimulate the gut? Because the gut's not moving, right, Sean? Because you just chemically paralyzed them. Why would you want to do that? Here's the thing. Neuromuscular blockade medication don't affect smooth muscle the way that affects skeletal muscle. Skeletal muscle is, remember, Nursing School 101, Anatomy and Physiology 101. Skeletal muscle is the muscle that you use to take a deep breath, to ambulate, to cough, deep breathe, make facial expressions. All of those external skeletal muscles, and some internal, are what's the question, what's the way I want to say this? Those muscles are innervated a different way than smooth muscle. And smooth muscle is the muscle that lines your heart, that muscle, that the type of muscle that lines the intrathoracic cavity, and it's also the type of muscle that lines the inside of your colon and your stomach and your esophagus. So smooth muscle is not affected the same way that skeletal muscle is when a neuromuscular blockade is given, whether it be by drip or IV push. If you give a what's called an NMB, neuromuscular blockade, or a paralytic, you are paralyzing mostly, if not close to 100%. You are giving close to all of the skeletal muscle is what's being blocked. So your smooth muscle are still going to work. Now, I said almost 100%. So I can't give you an exact percentage because I'm not that smart, but there are still some parts of your smooth musculature that are affected, but it's so small that it's mostly insignificant. So if you're going to feed someone who is on a paralytic, you want to treat it like you would treat every other patient. You're going to stimulate their gut gradually and make sure that they have a tolerance for it. Because if, let's just say, your patient is sick enough that they're laying on their stomach and they're prone, you're more than likely probably not going to feed them. Although we have done it before. So if your patient is chemically paralyzed, laying on their back, even if they're on pressors, as long as they're in a stable, they're stabilized, meaning they're not getting worse, that they're slowly getting better or they've plateaued, in most cases, we'll go ahead and feed them. We'll start trickling them, and over a 24, 48 hour, 72 hour period, sometimes 4 days, we'll sometimes go very slow. We'll slowly titrate up the tube feeds to make sure they tolerate it. There was a question during the live feed that asks, how much residual should there be in the stomach? Here's an interesting fun fact for you. Do you know how much volume your stomach can hold? The volume of your stomach is upwards of a liter. Yeah, a liter. Now, that depends on size, shape, BMI, and all that other good stuff. But the safe average is that your gut can hold up to 500 mLs of volume. That's food, water, fluids, so on and so forth. Can hold up to 500 mLs at a time safely without any problems. So the answer to the question is, what should your tube feed residuals be? This is something that comes out of protocol standards and guidelines from Aspen, and don't ask me what the acronym stands for. ASPEN, the Association of Parenteral blah 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 blah. Don't ask me, I don't remember, so don't go down there. Is the standard is less than 500, or in some facilities it can be 400, 450. As long as your tube feed residuals are in 300s, 400s, you can continue to feed them at whatever rate you're at, or you could increase them to their goal. And it's something that you're obviously checking every shift or every 4 hours, depending on your facilities protocols. So ironically, you not only can feed them, but tube feed residuals can be quite high. Check that someone's asking, can you, oh wait, so no, they changed their mind. What precautions do you take for preventing aspiration? So this is a critical care ICU standardized answer. Everything from making sure the oral cavity is dry and intact, so you don't want to have any scratches or wounds, to head of bed greater than 30 degrees. You should be using a chlorhexidine wash because the chlorhexidine actually removes the bacterial film not only from your mouth and from your patient's mouth and their teeth, but also what happens over time is that there is bacteria that creates a biofilm on the tubes that are in your patient's mouth and nose. So the ET tube as well as the gastric tube, they actually can create a biofilm of bacteria. So you need to scrub those things off, which is why you need to be doing aggressive oral care to prevent the VAP, ventilator associated pneumonia. I would assume that everybody in every ICU is practicing these guidelines. These have been standardized guidelines for at least the past 10 years that I've been practicing. Chris is asking, what about gastric bypass patients? Depending on the type of gastric bypass, it shouldn't matter. Now, if you have someone who is a fresh gastric bypass, then sure. I can't say for 100% certainty that there aren't some stipulations that you should follow. I would think that if you're unsure, you should ask your attending physician or even recruit the suggestions or the input from a surgeon, so they might be able to tell you. A lot of meshes is being retracted during the live feed, so I must be answering them appropriately. So thanks. Future video, path to wound care certification. Sorry, Patty, I have no experience whatsoever when it comes to wound care or wound care certification. And in fact, I stay as far away from that as possible. Wound care is not my jam, and it's something I avoid at all costs. Chris, I hope I answered your question there. And Cheryl, oh, Cheryl must have already got it, so. I'm going to stay on the live feed for a little bit longer, just in case somebody has some questions in regards to this particular topic. Or if you'd like to branch out into another conversation, going to stay on for a little bit. Chris is asking, I think, gastric bypass. There's different types of gastric bypass. The Roux-en-Y is one of many types of gastric bypasses. And it all depends on where the bypass is. Is it at the GJ junction, or is it something that they've stapled off? Have they done a complete gastrectomy, or are they doing something else that they're bypassing? So it's really specific, but I would still follow the guidelines that I suggested, because even in the worst case scenario, so think of it this way, those gastric bypass patients, eventually what happens is the part of the esophagus becomes their stomach. Now it's going to be smaller and it can't hold on to food as long, but it does still hold on to quite a bit of volume. So that part of their esophagus becomes their stomach, and it should function like a stomach, which is, I don't think it'll hold up to the liter. Fairly certain that ain't happening. But in my experience, over the past 15 years, we've never had the contingency of, oh, wait, they're a gastric bypass patient, we need to change our tube feed residual goal. We usually base it on patient tolerance more than anything else. Patty is saying, saw a patient in clinicals who was prone on a rotating bed, got massive pressure wounds. What criteria would cause the prone position, and how is that better than supine? Dude, now you're talking my jam. So Patty, that is called a rotaprone bed. And the rotaprone beds are not actually used the way that we used to. So the best description I can give, and I'm trying to get you a prop so that I can explain it. So we're going to imagine that this tube of lotion, yes, got to keep my hands nice and soft. This tube of lotion is your patient. This is their head, this is their feet, and you're laying them supine. So this is their back, this is their stomach, and you're laying them in bed. The reason why we use prone positionings for the treatment of ARDS. ARDS is acute respiratory distress or acute respiratory distress syndrome. I actually just did a podcast on scratching the surface about that. You should go check that out on my podcast. Um, and what happens in ARDS is that you get what's called leaky lungs. So the lungs are not holding on to air the way it used to. So the alveoli, instead of being sacs of air, the alveoli, I'm going to put down the patient for a minute. So the alveoli are supposed to have nothing but air inside, okay? The outside of this is the outside of the alveoli. And what happens in ARDS is that this non-permeable membrane becomes semi-permeable. So instead of stopping fluid from going into the alveoli where there should only be air, you have, what happens is you get holes into your alveoli's membrane, so then fluid gets inside, fluid goes into the alveoli, and you can imagine that you shouldn't have fluid where there should be air. Okay? So when you have someone who's in ARDS and leaky lung, all of that fluid is gravity dependent, so it's going to go down. So if you're laying on your back, all of the alveoli that are layering the bottom of the back of your lungs are going to be occluded. And the top portion of your lungs are the only portion that are going to get oxygen to your body. It's the only portion of the lungs that are working. So in the prone position, we're going to flip it so that now he's on his stomach. So now that your back is facing up. So all of those alveoli that were not being oxygenated are now being oxygenated because the fluid is actually going down. And then you put them back. You don't leave them on their stomach alone. You're going to rotate them. And that's a whole nother subject. But that's a great question, Patty. So prone position is in the treatment of ARDS, and it helps to oxygenate and to open up and recruit as many alveoli as you can possibly manage. Of course, someone had to ask a COVID question. So Nurse Dale, precautions, COVID droplet airborne. Some facilities require nurses to use surgical mask. If airborne, patients require negative pressure rooms. Negative pressure rooms few and far between, but we're not having that discussion. Thought, keep up the good work. I am going to refrain from having a conversation about COVID because it requires an entirely dedicated time frame. The short answer is we don't have enough resources. We all know this. It is the state of affairs that we have to live in. There are a lot of unsafe work environments. And I wish I had the solution. I don't have the money. It's not in my back pocket. And I don't have the supplies. They're not in my backyard. I don't know what the solution is. I do know it's going to get worse, and I do fear for a lot of lives. It's an unsettling reality that we're all having to deal with, especially those of us who are on the front lines. I can only hope that all of these companies who are helping mass produce supplies will get to the front lines in time. The way that I'm understanding it is that you're going to utilize an N95 mask or a PAPR, which is the positive air pressure system, the helmet and all that. You're using those when you are going to be exposed to aerosolized respiratory particles. So potential or known COVID patient who is being aerosolized, you should be in a negative pressure room, airborne precautions, N95 mask, or a PAPR. Is it happening around the globe? No. I know this not only from reading what everyone else is reading, but from talking with colleagues across the nation. I'm not about to comment on what's happening in my area of the world or in my immediate community because that would kind of violate all kinds of laws and I would most likely get fired. And that's not happening. So I'm there with you, Nurse Dale. I wish I had an answer. and we have told everybody that we can tell. We're going to continue to fight the fight. We're going to continue to utilize all the platforms that we have to try and communicate the needs and the wants and the concerns from the frontline workers. So it's a good question, and I know it's weighing heavily on a lot of our minds. This coronavirus is not something that anybody was prepared for in anywhere around the globe. One country at a time has had the rug taken out from underneath their feet, thinking that it wasn't going to happen, or it wasn't going to happen to them, or it wasn't going to happen as severe, or they had enough time, or they had enough people, they had enough supplies, or that it would not progress in such a horrific and violent manner. And every single country, including the United States, has been woefully wrong. I did a Facebook Live last week on my Facebook fan page. I'm hoping to spit it out onto YouTube. It's a week, actually it's almost 2 weeks old now, but there's some valuable information there that if you are interested, you can listen to it. Keep in mind it's 2 weeks old, so there's a lot of information that is not applicable, but it also talks about the epidemiology of the coronavirus and some of the facts that we do know. I want to thank everybody for hanging out on the live broadcast. If you catch this on the record, please make sure you pass it on to a friend. I would love for you to share this with your nurse crew. I'm going to try and do as many of these as I can. I need to hang out on YouTube just a little bit more, so I apologize for that. I'm going to get back into the video blogging groove. I'm going to try and make these what I call mini crit episodes. This is just mini critical care episodes on bite-sized information about critical care topics. If you have a topic, you can leave a comment down below, or you can message me on just about every social media platform I have. I'm pretty easy to find. And as always, make sure you check your own pulse first.